Privacy and Security Forum. So I hope it's been a good afternoon for you so far. I want to thank the staff who put the program together and also our sponsors for all of your contributions. So as we complete this first day, on behalf of the HIMSS Board of Directors, I want to welcome you all. It's great to see all the CIOs, CISOs, and other folks, stakeholders interested in this here for this forum. Just like many of you, I know how important the topic is because privacy and security of patient data touches every aspect of the work that we do. With the introduction of meaningful use, we have also expanded our emphasis on protecting health information to satisfy those requirements, and of course, improve the delivery of patient care. And we have an ongoing opportunity to improve the delivery of patient care by making sure the patients we serve know their data are safe. So we've already begun today to explore the best practices in privacy and security. We heard from Tim Zoff and his perspective. Lisa and Bob brought forward the analysis of the HIMSS annual security survey, and then this last session on patient matching. Tomorrow there's going to be another live interview conducted by the staff of Healthcare IT News, and they're going to cover the HIPAA enforcement with Leon Rodriguez, who's from the Office of Civil Rights. Other educational sessions tomorrow include best practices for mobile device security, cloud computing, data breaches, risk assessments, and health information exchanges. And as Mike said, Jennings and I are pitch hitting today, so tomorrow Jennings will be back for his talk in the afternoon. So I also, as the incoming HIMSS board chair, I look forward to the ways our organization is evolving to meet our vision of advancing the best use of IT and management systems for the betterment of human health. I see a couple of former board members in the room, Howard and Mike, Howard and David over there. And we want to thank those guys and their other boards before the one that I'm currently on for the vision about expanding HIMSS. Many may not know, but in addition to the annual conference that's here in North America, we now have annual conferences in Europe, Asia-Pac, and the Middle East as well. Several years back, we bought the HIMSS analytics database, which is that's the basis for the EMR adoption model, and that's expanding also to the ambulatory space. And we have an analytics database in other parts of the world as well. You know that we have probably 6,000 hospitals in the US, more than 5,000 of them are in this database. China claims to have 18,000 hospitals, and you can imagine some of the not only privacy and security, but technical issues around character-based systems and collecting the data on those hospitals, but we are at it. In addition, we're also expanding the HIMSS Media Group, of which MedTech is part, and it's really because of that expansion that we're allowed to have this conference today. And so we believe the growth and strength of the overall HIMSS organization is crucial to what we want to do as a mission, which is advocating for the betterment of human health worldwide. As chair-elect of the board, I have this unique privilege of being able to lead the annual strategic planning session for HIMSS. And I did this last week with the board members in New Orleans, which we always go to the city where the annual conference is in the December board meeting beforehand. We had a great time. We also invited members of the HIMSS Worldwide Board, so there was a physician there from Singapore who had made a great commitment to not only be at her board meeting, but stay for our shenanigans as well. So people probably know that for the last several years, we've spent a lot of time as an organization advocating for the things that are in the regulatory space. You think of meaningful use, the Affordable Care Act, ICD-10, and of course the privacy and security issues, and we will continue to do those and provide the toolkits and whatnot. But we've also been focused on these 6 other things: clinical and business intelligence, interoperability, mobile, e-connecting with consumers, helping small practices adopt information technology, and then usability and workflow. We will keep doing all of those things. They're baked into our operations. But the group also said that there is a really important emphasis that needs to be placed on value. We interviewed all 4 of the national coordinators for healthcare IT, and there's an anxiety now that we've spent all this money and continue to spend money on adoption of IT and emphasizing privacy, that we need to get the value out of it. And of course, the vision was always about outcomes and expense. Then also, we believe interoperability is a really important component of this, and not just technical interoperability issues, but really do healthcare organizations interoperate with data to make the healthcare experience better when we're paying for health as opposed to paying for a procedure. And then finally, I think we all know this, not only are people going mobile, but we are connecting more and more, and the patients, the patients ourselves, need to be involved in this accountable care process. So HIMSS will put emphasis on that. So this is a bit of a non sequitur. I've been up here as chair-elect guy, and then I'm going to go over here with Jennings and be the deputy CIO of Partners guy. But again, welcome and thank you for the chance to greet you.
Hi, my name is Mike Miliard, and I'm managing editor of Healthcare IT News. And I definitely want to thank Scott and Jennings for pinch hitting today. And I'd also like to thank Imprivata for helping make this session possible. And the hope is that we'll leave plenty of time for questions, and you guys can get some really useful information from some people who are really ahead of the game in so many ways. The first question is a general one. A lot has changed over the past decade, and especially over the past 3 or 4 years with high tech and meaningful use. And the technology's changed, and the regulatory environment has changed, and the nature of threats has changed. So, from your perspective, how has your strategy to deal with privacy and security issues changed and evolved along with it?
So first, thanks for having me today and tomorrow. I'm glad to meet with my fellow security and privacy professionals and all the stakeholders. And that's an interesting question because, and I'll make this a little bit personal in terms of my answer. I've worked in privacy and security my entire career. I left law school and just wound up working in privacy at the Department of Public Health in Massachusetts. And initially I started working because they needed attorneys who could help with all the regulations and things, and that was really kind of the big driver, I guess. And just in terms of thinking about the answer to your question, it just seems like it was a simpler world back then in 2002, right? We didn't have iPhones and all this consumer technology kind of working its way into the organization. Didn't have expectations of ubiquitous wireless and ubiquitous technology. And then just in terms of, the regulations themselves, there really weren't any teeth to them. CMS really didn't know how to enforce them, and so it was just kind of this thing that was there, and people did their best to comply. And I think the real thing that seems different to me is that I feel like we're at an inflection point as organizations dealing with privacy and security, in that it's just a different ballgame, And to echo some of the themes from the keynote today, the expectations of privacy and security in terms of how we actually meet those objectives is just dramatically different. Again, going back to those concepts of ubiquitous computing, wireless, and having just so much data and so much technology in the healthcare environment, and that really wasn't the case back a decade ago. So with that, you also have this whole new set of well, I wouldn't say new regulations per se, but the regulations actually have teeth. There's enforcement actions. We have the KPMG audit activity, and it just seems like the expectation is that we're going to comply with these bodies of law in a way that we really never did in the past. So we're trying to comply with something that is much different, and it's much harder to kind of contain, and it's much larger and messier. So I think in terms of, at a practical level, our organization is really trying to come to terms with how to meet this different environment, both in terms of technology, consumer expectations, the expectations of our workforce, as well as just simply the expectations of the regulators. So we've actually have spent several months looking at our overall privacy and security program. We're making some changes both that are structural, trying to really integrate the programs, and really trying to think through kind of a long-term roadmap to this different environment. And I can't say that we have all the answers. In fact, we're struggling like pretty much everyone in the room. But I think the thing that we really have tried to do is acknowledge the different environment and to really do our best to understand what that environment is and to align the projects that we need to engage in to meet the challenges of that environment. And the last thing I'll say is that we really have recognized that in the current environment with the changes, we can't achieve the goals of privacy and security without having management on board. And so, literally today, I met with our audit, finance, and compliance committee with some of our board of directors present, and talking about the need to have management really backing this new strategy, because the reality is it's just so large. So again, I'm echoing one of the themes from the keynote, but this is an enormous thing we're trying to undertake. It's much different than the little compliance activities that felt almost like you were checking boxes off in 2003 and 2005. This is about changing culture and dealing with an entirely different kind of technology and threat landscape. So again, I don't think we have all the answers, but we're trying to do our best to really make this a concerted effort to meet the new environment.
And I would just add, I think like many of you, when the HIPAA rules went into place, we managed to make people aware of the privacy standards and had a lot of activity in terms of training and through our compliance offices and our directors of HIM and whatnot. So that was socialized, but the security portion always lagged. And I may not get the timing right, but I think we feel very lucky to have Jennings. You've been here 4 years, is that right? Close, almost 4 years. And Jennings alluded to that we're making some organizational changes. He's been a man alone for the last 4 years, and we're finally putting some structure into that office, which I think is critical. And so that's another indication of how we're changing and responding. Another piece that was very difficult for us over the last 5 years, like all of you experienced, was mobile device encryption, and we botched our first rollout of our product for laptop encryption, and we're still paying for that and hopefully getting better. So,
Jennings, what keeps you up at night? There's no shortage of threats out there. What are the ones that are always on your mind?
I guess going back to my first answer, the enormity of the situation and the need for real cultural change, I think, is what really keeps me awake. I think about one of the biggest challenges I have is in terms of, it's about people. Security is not really about technology, and it's not about policies and things. It's really about getting people to understand their responsibility. And there's many ways to secure, a device, or many ways to secure a way someone works with data. The real question is, are they on board with what you're trying to do? So what keeps me awake, frankly, is the clinician who views security as, an impediment to doing his job and doesn't want to listen to, any of the messaging that I'm trying to get across about the role that security and privacy play towards clinical care. The other thing that really keeps me awake is also just, frankly, the consumerization of technology, and that term has a pejorative meaning, and I don't want it I don't want folks walking away that I think this is a bad thing, because I think, frankly, a lot of the consumer technology is coming into the workplace because it's better than what we've offered from an enterprise perspective. I mean, enterprise technology stinks at times, and the consumer technology is easier to use, and and I think the other related to all this, and what keeps me awake, and I'll tell a little story. About 4 summers ago, I was at a party for a wedding, and this guy tapped me on the shoulder, and I turned around, and he's a very tall, stately gentleman, and he says to me, "What are you going to do about my 86 passwords?" And I was like, "Who are you? What are you doing?" And it turns out he was one of the chiefs at Brigham and Women's Hospital, and his daughter was actually marrying a good friend of mine from high school, and they had told him what the job I was about to start with partners. And that's part of what keeps me awake too, is this feeling within a lot of our clinical areas and with clinicians and nursing staff, et cetera, that security is an impediment, right? And so that is really going to be one of the primary things that we're working on as an organization, is really trying to change the culture to get people to understand that security is about, security is part of the care team. And that's really, the failures that we've had as an organization, like around that laptop deployment, they leave a bad taste in the mouth of the people we're trying to work with. So that definitely keeps me awake.
For me, it's how data migrate and finds its way onto thumb drives and other mobile devices that aren't encrypted and out there. Back to the privacy issue and socialization, you all remember the times in the past when a group of clinicians would get into an elevator and talk about Mrs. Jones's colonoscopy. And somehow we've been able to put those signs up in elevators, and at least around our hospitals, the practice is to keep privacy to themselves. We haven't achieved that yet with security, and the ramifications of carrying around PHI or something on a mobile device. A lot of the things that anytime we have an incident, it's usually a clinician who's left an iPad in a taxi or something.
You know, could you talk a bit more about how you go about kind of fostering a culture where privacy is the lens through which patient data is viewed? And, you know, what does it take to get physicians and clinicians and nurses to buy into this? Do you have to, you know, kind of browbeat them, or is it just a matter of setting a right tone, or, you know, what specific steps do you take to kind of foster that culture?
Well, it's all of the above plus several others. There's no one single way of getting messaging across in an organization, particularly large academic medical centers that are part of our system. So we've taken kind of both a top-down and bottom-up approach. I mentioned earlier, you know, the presentation that we gave today to our audit committee. We've worked for several years really educating, you know, clinical leadership about the need for security and the role it plays relative to patient care, research, et cetera. The one good thing has been that several of our board members, they come from verticals that are ahead of healthcare, so they're aware of a lot of the controls that we need to have in our environment. Another thing we've really tried to do is just think about the messaging itself and have messaging that resonates with the clinicians. So I'll be honest, I don't talk about data confidentiality when I talk to clinicians. They don't care about that. And I can't say I blame them in that the EHR products they use are really set up to basically say, hey, everybody can access a record. So the technology doesn't enforce the concepts. It's not a good message. And frankly, you know, when a patient shows up, the last thing they want to be bothered with is, you know, a lot of passwords and all this complexity around who can see the data. They want to see the data to treat the patient. So I try to really focus on messaging that involves data integrity and data availability. And that's a theme. Those are themes that will get the attention of most clinicians. If you explain to them that, you know, the failure to patch a server could lead to data having values that are corrupt, and then a patient presents and those values are no longer accurate, that's a message which really resonates. I know for the CEO of our system, it's something that he talks about every time he talks about security. Data availability is another thing. Just having the data available, not only having integrity, but availability is just really critical. And my advice to peers of mine that are really struggling with getting the word out is to you know, tailor their messaging to what resonates with a clinical audience or a research audience. And then I guess the last thing I'll say is that we really try to embrace the concept of having, you know, champions. So one of our hospitals, MGH, Massachusetts General Hospital, we have this little corny campaign where we walk around with a cart that has lollipops on it, and it's called POPs, and protecting our patient privacy. And it sounds a little corny, but we have clinical folks who really have taken they really champion this effort, and they will work with, you know, their peers who are kind of grouchy about these concepts, and they'll really be advocates for what we're trying to do. And the other thing I guess I'll say along those lines is that persistence really matters. You know, I am more than willing to go and talk to that angry, you know, person. So as an example, there was this really angry researcher who one day emailed me and compared me to a communist Chinese dictator. And what angered him was that his iPhone one day had a 4-character PIN that he had to enter after 15 minutes of inactivity. And, you know, I didn't let that go. I chased the guy down, talked to him, and I don't think he was convinced with the messaging, but I think, as anyone in this room knows, you know, you got to be persistent if you work in a privacy or security role, and I think that's really the key to executing on that.
Yeah, actually, on the subject of smartphones, I see a whole lot of iPhones and iPads here, and I'm presuming most of your doctors like them and use them too. So what do you do? Do you have BYOD policies, and, you know, what are some of the strategies you have in that sphere?
So we're in the process of really actually finalizing our approach to BYOD. It involves a couple different things. And in fact, we've had policies for years requiring encrypted smartphones and whatnot, like a lot of organizations, but, you know, people ignore that. That's the reality. So we will be leveraging different technical capabilities in our Exchange platform as well as in our BlackBerry platform to really block devices that don't meet our policies. that actually goes live in about 40 days, and we expect a lot of anger, particularly from the users of the Android platforms, because that platform is very fractured, if you will, and it doesn't comport with a lot of the policies we're pushing out. But the other thing we've tried to do as well is really adopt a policy we can educate our workforce around the risk associated with these devices. So as an example, some senior leaders in our organizations have lost iPads, as Scott mentioned, and they've known the policies, and they've called us up and said, hey, I've lost my device, and we remotely wipe it and erase the data. But we really haven't educated our standard workforce about the fact that we need them to kind of help us out with that. So we want them to call us if they lose the device rather than disable the cell signal and we can't wipe it. And not to get into the weeds about this, but really the onus is on the users, right? It's on them understanding their obligations. So in the January timeframe, we're also finalizing a policy describing the acceptable use of consumer technology brought into the workplace, and it will really go into detail around the need for users to understand their obligations around securing the device while traveling, not sharing it with their children, so that means their iPhone can't be handed off to their 2-year-old. And my daughter loves my iPhone, so I have a separate one just for her that has no work-related data. But that policy will actually be a really big push, and we're going to actually try and require every single workforce member to attest to having read and agree to the policy, because it's going to be a dramatic change for our workforce.
Do you want to tell them about Gary and have his personal data?
Well, yeah, I guess I will mention this. One of the senior folks that actually we've remotely wiped their device was our CEO, Dr. Gottlieb, and he was kind enough to call us, and we wiped his device, but it meant he lost basically all of his personal data that was on the device because it was a BYOD device. And that's going to be one of the real challenges organizationally, is really educating folks that, and this is the challenge with the BYOD space. We support the device to a certain point. We help you connect to email, get on the wireless network, but that's it. So those pictures of your daughter and any personal correspondence, you're going to lose them if we wipe the device. So part of our organization's strategy is not to try and compartmentalize that personal data. We know people put it on the device. We're basically going to secure the entire device, because we expect users to download apps, and they're not just putting corporate data in email. It's going to be on the camera app. It's going to be on the other apps that they download, because they have a lot of discretion around those devices. So we're going to secure the whole device and treat it like we did our CEOs, which is once it's lost, it's ours, and we're going to remotely erase every ounce of data on that device.
How do you keep on top of new regulations and dealing with those, and also dealing with old legacy technology in light of new and forthcoming regulations still to come?
Well, it's a real challenge. I mean, at some level, we're always waiting for the new regulations to come out, and we obviously pay attention to all the trade journals in our council. We have our contacts in the various regulatory bodies, whether they be in DC or in Massachusetts. I try to attend the annual OCR NIST conference every year and talk to David Holtzman and folks. But I think the real challenge is not necessarily that the regulations are changing, even though they are. I think the real challenge is trying to get the organization to a position where it's not so focused on the regulations, because the regulations, frankly, they're about this deep. And if you look at like the KPMG audit activity, they're asking questions around how people access data that aren't described explicitly in the regulations. So to echo another theme from the keynote, our organization is trying to take an approach where the regulations frankly don't matter. We're trying to build a standards-based program based on standards from ISO and NIST in general. We are not actually a high-trust shop, but there's certainly overlap between those standards. And one of the mantras that I've been saying since day one was, let's stop chasing the law. Because it's a losing strategy. It's a strategy you do when you're kind of immature and you're building your program. But if you have a good program, you have regulations, you follow standards that you can map back to the regulations. And frankly, that's something that's easy for a large organization to do. I think for small providers, that's going to be a real challenge. As it relates to legacy technology, we're in the process of defining a variance process where we formally grant variances to legacy technology that can't comport with new technology standards or security standards. There's no way to force some of our systems, as an example, to have that 8-character PIN. But through conversations with regulators, what they have said essentially is, that's okay. You have to implement compensating controls to reduce the risk so it's consistent with the goal of a regulation. And you have to document your analysis. Regulators don't want you to analyze these situations with legacy technology and just kind of do it in the back of your napkin. You need to be a little more formal than that. You need to keep that documentation. And I will point out that CMS itself has, or HHS I should say, has variance procedures and policies themselves. They have legacy technology. So it's not like this is a problem that's unique to healthcare providers. Our own regulators have it. So again, just to kind of, I guess, summarize, we're really trying to stop chasing the law, to really take a standards-based approach to our compliance. But we do pay attention to it, obviously, because it's a very important thing, and we're all waiting for the omnibus HIPAA updates to be finally released, and I have no idea when that'll occur.
And I would just add operationally that we do have this standards-based approach, but the Jennings office, our internal audit folks, compliance, and OGC all do a great job in keeping up with these things. And we've also deployed tools like HealthStream, an opportunity to have folks take a training online and then be recorded that they did take it. We've got that in most of our hospitals. We're rolling it out for corporate folks. And there are various tools like that we're looking to educate folks along the way as well.
Just two brief questions before we open up to Q&A, because I'm sure there's a lot of them out there. But Partners is obviously at the leading edge, of care delivery. You're one of the best, providers in the country, and you have plenty of resources to kind of help you with some of these challenges. What advice do you have for other types of providers, small, critical access hospitals or physician practices, or we've seen the numbers. A lot of these people aren't dealing with this much at all. Where does someone even start?
Well, I'd beg to differ about the resources thing. I think seriously, I talked to some of my peers at the large AMCs around the country, and security and privacy are not necessarily the well-funded parts of IT budgets, and that's changing. I can't claim to be in the position of a small provider, let's say. I recognize they have difficulties that go beyond it, but I think it's a real challenge because. I'm a dedicated security professional. We have dedicated staff, and clearly small providers don't have that luxury. And I want to make clear, too, in the Partners Network, we actually do have some small providers, and their security needs really became of issue over the past year, as a lot of them were seeking to attest for meaningful use as eligible physicians or providers. And the thing that really was a problem for them was conducting the risk assessment. Frankly, a lot of them hadn't, and they didn't know how to go about it. And so we had to put together a strategy for providing advice to these entities that refer patients to our hospitals, but they're not part of our entity, and we really can't give them legal advice. So there was a lot of care and thought put into how we engage them, and essentially there was a few recommendations we made. First and foremost, OCR has actually published guidance for understanding HIPAA. The guidance was first published in 2007, and some of it's been updated over the past several years, including a document for small providers. I don't remember exactly when that was published, but they're nice high-level summaries about what HIPAA is, what a small provider's obligations are relative to a large provider. They provide overviews on how to conduct a risk assessment. But I think realistically, it's pretty dry reading, and it's going to be hard for a very busy, provider office to actually digest and make sense of a lot of it. So the other thing that we really asked actually the providers to do was many of them had IT consultants that provided, basic network connectivity. They provided assistance with setting up their EHRs. We basically helped them engage those providers to look at the security and actually perform the risk assessments of their small practices. Many of their IT providers could do that. So I think one thing that I would actually recommend is, the small providers don't have to go out on their own and do this. They don't have to build massive security programs. They should actually look to, the IT shops that provide connectivity, their ISPs, to see if they can help them. And our experience has been that there's plenty of assistance out there to help people do a risk assessment and to look at their security program from a very reasonable and scalable perspective relative to the size of these providers.
I think we're, agreed with Jennings, we're proportionately challenged. I'll give you a few numbers. We have 100,000 logon accounts. We have 50,000 standard computers in eastern Massachusetts and another 30,000 non-standard. We have 80,000 email accounts. So plenty of resources could be challenged. In addition to what Jennings said, obviously, you know, I would put forth HIMSS as a great resource, the materials we have in the toolkits and the web, and then getting together with forums like this.
And finally, my last question is, what's atop your to-do list for 2013?
Well, I mentioned earlier we're taking a real hard look at our security and privacy program and trying to think about how do we really take it to the next level. And frankly, we're trying to map ourselves against verticals other than healthcare. You know, healthcare hasn't done security and privacy very well. I think privacy better than security. So we're looking to other industries. As far as kind of more tactical things, we're looking at desktop encryption. We really focused on portable device security. Now we're looking at desktops, recognizing that they get smaller and smaller and they get stolen. And also looking at, as an organization, we're actually thinking of leveraging managed security services to actually help us secure our network better. I think one of the struggles for healthcare is that security is really not a differentiator for our bottom line, in the sense that, you know, we're not going to build these massive security programs of giant security operations centers with lots of very expensive security professionals, including ethical hackers, in our employment. It just doesn't make sense. So we're trying to look at how we can leverage managed security service providers, that we can outsource some of our security activities, such as monitoring our firewalls, et cetera. You know, these organizations do this 24/7 by 365. We can't afford to staff our security program that way, so that's one thing we're looking at. And then I guess the other thing I'll say is that we are continuing to look at just education and awareness. Our education and awareness really, it's been focused on kind of, you know, policies, and not really something I think that really truthfully resonates with our users. So we're looking to create a real branding strategy for our security and awareness strategy. We actually are calling it Keep It Safe and Secure. That's why I kept saying keep. And we have a nice logo and an intranet site, and we're looking to really actually have professional grade marketing resources to really reach out to our workforce. And as part of that, one of the things coming from my office will be a monthly newsletter that's focused on security, that's not frankly about security in the workplace. It's about security just for you, the average user of technology. Things like, why is the Starbucks wireless network insecure, and what should you know about phishing and keeping your kids secure while computing? Because the idea is that that sort of stuff will translate into the workplace, and we can create kind of this mindset that security is something that affects any use of technology. And so our, again, maybe some of this is something we can do because of resources, but we're trying to take a creative approach to focusing on the person, because the person is what's really critical to security. It's not about technology. It's not about how many policies you have. It's about getting that clinician to understand they have to pause and think before they bring a new device into the workplace.
Very good. Any questions?
Hi, Lisa Gallagher from HIMSS. I just was wondering, to what extent are you taking advantage of virtualization, cloud computing, and how is that affecting your security resources, your compliance posture, everything?
You want to take one first?
So thanks, Lisa. I'm not sure Jennings can speak to how it might be affecting security. We are virtualizing our server infrastructure, about half done with that of perhaps, we don't think it can be 100% virtualized anyway, but half of 75%. And we will continue to look at virtualization and automation strategies across the stack for storage as well. And so do you have comments about security?
Yeah, and I think one of the things about virtualization that's really important is that it does reduce your physical footprint. And our approach is really going to allow for me to work with some of the teams that report to Scott to leverage standards from NIST and CSI Institute to look at virtualization security. We've been deploying it in what we think is a secure model, but thankfully there's a few new standards that have emerged that we're going to leverage to look at the environment, and it'll be a project that we tackle next calendar year.
one of the stronger political sections of the organization that I represent is the clinical quality assurance organization. I feel like that would be a great way to address the security issues, and one way to speak to them would be to be able to put things in quantitative measures. Can you touch on different metrics that you might be using to say, here's improvements that we are making in security?
Sure. So I'll be honest, we're actually very mature in the use of metrics for our security program. I don't know how much people know about partners, but as an organization, we have many hospitals, and we frankly do not have as good a job around aggregate reporting around incidents and other sorts of things that are security metrics, if you will. So that isn't to say that we don't have a plan to really expand our usage of that or to really work in this space. So one of the first things we're going to be focusing on is really in the category of incident response. And there's a spectrum or a taxonomy of incident types that we plan on really centralizing the reporting around those potential incidents. Second, there's also help desk statistics that we really want to leverage around everything from forgotten passwords to calls to the help desk around phishing incidents. I will actually mention one of the things we're doing too. A real problem for our organization is phishing and having people give out their credentials to remote attackers. We've actually started phishing our workforce. We're using a product from a company called Wombat, and we send phishing messages to our own workforce. They receive it, and a certain number click the link, and they get to this little training cartoon that says, hey, you've been phished. This is not a good thing. Let me explain what phishing is to you. And we're actually getting some really interesting metrics there. And phishing is a really important issue for us because when it happens and we learn about it, we shut down the account, and then that clinician who wants to go and treat a patient finds that their account's been disabled, and we do not enable it typically unless they've had a conversation with a security official of some kind, unless of course there's a patient care critical issue. So there's definitely metrics there that we'll be able to mine over the coming months around how clinicians are affected by this effort. One thing that we've seen over the past 6 months is that calls to the help desk have increased by 6 times, or a factor of 6, of people just noticing that, hey, this is a phishing email. We still are kind of stuck with about a 16% click-through rate, but we're hoping that by the time we go around, that'll improve. But so to kind of summarize, I don't have a good answer right now because we're building that program, but some of the initial areas we'll be focusing on are incidents, help desk tickets, and in particular around phishing, which is a big problem in our environment.
Cell phones, text messages. I have severe concerns about, that information being picked up wirelessly and misused. There are numerous products that I've looked at that, as long as you use their phone book, so to speak, or their app on the device, it secures the message. But there's no way to force people who have their devices to go that route. I work for a private practice. We're rather large, but they all own the business, so forcing it isn't always an option. Education is great, yet I still sit here. It keeps me up at night, candidly. So, any thoughts or any ideas about how you're dealing with that?
So I wish I had a good answer. We're actually starting a project in January to take a really hard look at this, and what makes it challenging for our organization is that we clearly can't even issue a simple edict saying, hey, don't text, because first of all, people will ignore it, and you hate to have policies people ignore on the books. That's a bad thing. Your auditors always flag that. But also the reality is, we have emergent situations where patients who are, dealing with mental health issues, as an example, will contact their counselor and say, hey, I'm suicidal, I need to talk to someone. And I wouldn't feel comfortable telling that counselor, sorry, you can't respond. You can't send PHI over that insecure channel. In fact, I'm going to tell them, please do that, And that's one of the areas I think that we struggle with in terms of the regulations, is they really, at least with HIPAA, I guess one can make an argument that it's not reasonable and scalable to encrypt during that circumstance, but some of the other privacy regulations like FERPA they really have explicit emergency kind of provisions that make it easy for a provider to understand their obligations, and I wish HIPAA was explicit that way. Anyways, back to the topic at hand. So what we're trying to do is really take a cross-disciplinary organizational look at these issues. We have an innovation group that is actually looking at expanding the use of texting to reach out to patients. Right now they're really focusing on things like reminders and very basic things that contain de minimis PHI, if at all, but the plan is to expand it. And, to date, our focus has been securing the device people use, at least it's saying that, okay, they're using an encrypted device, but you have to worry about the transport channel and whether or not that's encrypted. So I unfortunately don't have a lot of good answers, but I certainly would be willing to provide, examples of what we come up with, and I'd like to talk to other people about what your institutions are doing, because it's not something that we'll be tackling alone. And one last thing, I think you're absolutely right, those apps, I'm a little skeptical. And certainly when you talk about texting to patients, forget it. They're not going to want to use any of those apps. They want to use the app that came with their device, and they want to have the conversation with their friends and their spouses right next to the conversation with their doctor. So our solution has to acknowledge that.
One more question before we wrap up?
To follow up to Lisa's point on virtualization, I know you commented on the server virtualization. On the desktop virtualization, to help, obviously, with the proliferation of desktops you have to manage, and to secure them in a central location since you're going to a managed service or looking at a managed service for security, how are you looking at, and how is desktop virtualization being looked at to help, minimize your risk, keeping things centralized? Or do you see it as an inhibitor?
I can comment on what we're doing operationally, and then Jennings can comment on the security aspects of it. So we have been, I think people may know that we're going to be implementing Epic across our enterprise, and so obviously there's a virtualization component of Epic using Citrix XenApp, really server-side virtualization. We have done some virtualization on the desktop really just around Microsoft Office 10. And I think what you're really talking about is VDI and back-end hosting of remote PCs. And we did an evaluation of that several years ago, decided to go the XenApp route for other applications as well as Epic. And we will look at that again, but right now there's not a strategy to go to a VDI type of situation.
And I'll just say that from my personal perspective, I'm a little skeptical of the role of virtualization at the desktop in healthcare, because so much of the applications that run especially in large academic medical centers, there's so many applications that trying to virtualize all of them just doesn't operationally scale. We're going to have a significant footprint of standard OS devices, and particularly in the research space as well. I'm skeptical of virtualizing SaaS as an example. I mean, I know there's organizations that try it, but so I think we're really focusing on securing the endpoints and looking at strategies like NAC and locking down which devices connect to our Exchange platform rather than relying on virtualization of the endpoint.
One more question from Lisa.
Social media. So, in talking to our members, this is coming up as a security issue quite a bit, and for the reasons that you might think, leakage of PHI and unethical behavior and things like that. But we're also seeing some attacks coming in that way, phishing attacks and other things, and I'm just wondering what you're seeing and how you're dealing with it.
So we're seeing all of the above. And there's some parts of our organization that just ask us to ban social media, and I've been pretty clear in terms of my leadership of the security program. The answer is no. And we have parts of the business that rely upon it just like other folks here do. I mean, we rely upon Facebook for patient outreach, and and frankly, in terms of the water cooler problem of people wasting their time at Facebook or whatever, that's a management issue that you'll have no matter if you block this or not. So we've implemented some technology from Cisco that actually helps us look at social media or any website or any sort of HTTP-based traffic, if you will, to see if there's malware or something coming that day. So there have been times where for 48 hours as an example, Facebook's been blocked, and it's been due to like a compromise in Facebook or, you know, some sort of cross-site scripting vulnerability or something. We've blocked the New York Times, and that upset some people. And there are categories of content we did, you know, agree to block, such as gambling, hate speech. But even then, we have exception processes to allow people through who need it for legitimate corporate purposes, and there are some people in our environment who do. So, you know, I don't think we have a perfect answer, but we're relying on technology from Cisco right now to help us, and it's providing, we feel pretty comfortable about it, but we know there's things that get through. There's no perfect technology because a lot of these are zero-day exploits.
Okay, well, thanks to you both. This has been a really, you know, great informative session, so we really appreciate it. Thank you.
All right, the reception is right outside. Jennings will be back tomorrow afternoon for another panel on cloud computing. And we have a bunch of similar panels tomorrow on risk assessment, securing mobile devices, breaches, culture. So it'll be another interesting day. Thank you very much.